What is OCD, obsessive compulsive disorder? It's a neuropsychiatric condition that is somehow common, with a lifetime prevalence of 1 to 3%. Patients with OCD have obsessions, that is, repetitive and persistent thoughts that cause distress or anxiety, and compulsions, which are attempts to ignore or suppress those intrusive and unwanted obsessions. Compulsions are repetitive behaviors or mental acts that the person feels driven to perform in response to an obsession. Compulsions are meant to neutralize or reduce the person's discomfort or anxiety. We all obsess about something occasionally, but in persons with OCD, their obsessions and compulsions are time-consuming. They may wash their hands time and time again because they obsess about the unreasonable health risks of contaminated hands. In patients with OCD, their obsessions and compulsions reduce the quality of social, academic, and occupational functioning. The age of onset appears to be bimodal, with onset either during childhood, around 10 years old, or during adolescence or young adulthood, around 21 years old. Data from randomized trials strongly support the use of exposure and response prevention therapy for OCD. This therapy is exactly that. Patients are repeatedly exposed to fear-eliciting stimuli or situations combined with strict prevention from engaging in compulsive behaviors. Fear-eliciting stimuli or situations are presented in a progressive manner, beginning with moderately distressing ones and progressing to more distressing cues. The psychotherapist then instructs the patient to abstain from the compulsive behavior that the patient believes will prevent the feared outcome or reduce distress. The purpose of these exercises is to allow the patient to experience a reduction of the fear response and to recognize that these situations are not high risk and to learn that anxiety will subside naturally even if the patient does not make efforts to avoid it. Multiple randomized controlled trials have shown that around 60 to 85% of patients show a considerable reduction in symptoms with use of exposure and response prevention therapy. In addition to this form of psychotherapy, some medications like SSRIs, that is, selective serotonin reuptake inhibitors, have shown efficacy in patients with OCD. Approximately 40 to 65% of patients with OCD show a response to SSRIs. However, the probability of full remission with the use of pharmacotherapy alone is very low at around 10%. So exposure and response prevention psychotherapy has a greater benefit than pharmacotherapy. Exposure and response prevention is the first-line treatment for patients who are motivated to cooperate with demands of the therapy, who do not have severe depressive symptoms, or who prefer not to take the medication. In the case of patients who find exposure therapy too frightening, an SSRI should be started first, and then exposure therapy should be initiated after the medication has reduced some of the OCD symptoms. Overall, the clinicians should let patients know that OCD has a low frequency of spontaneous improvement, but a high likelihood of responsiveness to therapy.